Welcome, everyone, and thank you for joining the Children's Hospital Colorado Newborn Screening Virtual Education Series. Today's topic is cystic fibrosis and severe combined immunodeficiencies. As our virtual education series is designed to be interactive, we strongly encourage audience participation and all questions are welcome. So please note any questions or comments that you have for our presenters, and they will be happy to respond during Q&A. Right now, everyone's microphones and cameras are muted. At the end of the presentation, we will unmute microphones and begin taking questions from our audience. Participants are also welcome to submit questions via our group chat feature. A quick tips handout to include instructions on how to access group chat and submit questions was sent to all registered participants. Please allow me to now introduce our speakers for today's session. Dr. Scott Sagel, Professor, Pediatric Pulmonary Medicine, Children's Hospital, Colorado. Dr. Sagel is a pediatrician who cares for children with cystic fibrosis and primary ciliary dyskinesia. He is the director of the Pediatric Cystic Fibrosis Program at Children's Hospital, Colorado. He also oversees the care of children with primary ciliary dyskinesia at Children's Hospital, Colorado, throughout his involvement with the National Institute of Health-Funded Genetic Disorders of Mucociliary Clearance Consortium, a rare disease clinical research network. Dr. Sagel is a professor of pediatrics at the University of Colorado School of Medicine. We also have joining us today Dr. Elena Shea, Assistant Professor, Pediatric Allergy and Immunology with Children's Hospital, Colorado. We also have Dr. Colin Duttmer, Assistant Professor of Pediatric Allergy and Immunology with Children's Hospital, Colorado. Unfortunately, Dr. Duttmer is unable to join us today, so Dr. Shea will be presenting on his behalf. Thank you all again for joining. Let's begin.
Sounds good. Sabrina, thanks for the introduction. So we're going to start off speaking about cystic fibrosis newborn screening. By way of disclosure, I am the director of the CF Center here at Children's Hospital, Colorado. I also receive grant funding for the work I do from the Cystic Fibrosis Foundation and the National Institutes of Health. For this presentation, I'm going to go over the following agenda items. I'm going to provide a brief overview of cystic fibrosis, then turn towards newborn screening, discussing the benefits and risks of CF newborn screening, speak more specifically to the Colorado algorithm for newborn screening, and end the presentation with a number of different scenarios you as clinicians in the community might face. So cystic fibrosis is a syndrome of chronic sinopulmonary infections, malabsorption, and nutritional abnormalities. It is one of the most common lethal genetic diseases among Caucasians, inherited in an autosomal recessive fashion. Median predicted survival is now in the mid to upper 40s for people with CF. The reason for CF is there is a gene in our body that encodes for a protein that we call the cystic fibrosis transmembrane conductance regulator protein, or CFTR protein. This protein functions primarily as an ion channel, helping to control the movement of salt and water into and out of cells. In terms of the organ manifestations and where disease occurs, it really occurs where the CFTR protein is normally expressed and functioning. So when that CFTR protein is either not produced or is not functioning appropriately, you get problems in the various organ systems, from the sinuses where people have sinusitis to the lungs where the problem is really centered on the airways. There's schematics here on the right side showing a normal airway on the top and a CF airway on the bottom, where there's a buildup of mucus in the airways, really leads to chronic bronchitis, infection, and inflammation, and ultimately damage to the airways, to the muscular and cartilaginous framework of the airways, leading to a condition called bronchiectasis. There's also significant organ involvement in the digestive tract and the pancreas. So the pancreas we'll speak to more of. There's blockage in the pancreatic ducts that leads to problems problems with digestion of key nutrients. There's also problems in the intestines and then in the reproductive tract, particularly in males. So when we think about treating cystic fibrosis, again, speaking from a perspective of newborn screening, really the first thing we do is treat the digestive abnormalities. Because most people with CF don't get their own endogenous digestive enzymes into the intestines, we can start digestive enzyme treatment right after diagnosis to help patients to absorb particularly the fats and proteins they eat and to grow appropriately. In addition to a lot of nutritional support, lung treatments really are the mainstay of treatment for people with CF. We do a variety of different treatments to help clear mucus, both mechanical devices as well as inhaled mucolytic therapy to help break up and mobilize the mucus secretions. Airway infection is a cardinal feature of people with CF, so we use a lot of antibiotic therapy, oral, inhaled, and intravenous antibiotic therapy to treat them. We also use anti-inflammatory therapeutics as well. In addition, we do, in many of our patients, sinus-based treatments, and then there are patients with CF who have comorbidities, including liver disease and CF-related diabetes. This is an insulin-requiring form of diabetes. We're now in an era where we can actually treat the basic defect in CF, so we have the emergence in the last decade of what we call Cftr modulators, or protein rescue treatments. These treat people with particular mutations. So not everybody with CF benefits from these treatments. There's a lot of work going on into gene therapy, which is replacing the whole gene, and gene editing, which is repairing the sort of abnormal base pairs within the gene. And I'm hopeful that gene therapy or gene editing will be a reality for our patients sometime in the next decade or so. The ultimate goals in terms of CF treatment are for our patients to remain healthy, to maintain optimal lung function and growth, and participate fully in activities, both as children and into adulthood. This schematic is showing survival in cystic fibrosis over the years from the time that we first knew about CF in the 1940s and 1950s, where you can see it was an early fatal childhood disease with the introduction of digestive enzymes, chest physiotherapy, and other forms of mucus clearance, as well as a variety of antibiotics that were being developed. You can see that survival started to improve into the mid to late teenage years. The CF Care Center network was formed in the 1970s. We here at Children's Hospital are an accredited CF Care Center, providing the multidisciplinary care that the patients with CF need. Then there was the development and approval of a variety of different CF-specific therapies, including pulmozyme or recombinant human dornase, which is an inhaled mucolytic, inhaled tobramycin or Toby for those with a particular infection called Pseudomonas, another antibiotic inhaled as Trianam, and then it was really in the early 2010 period, this decade, that we started to see the emergence and approval of several Cftr modulators that treat the protein abnormality. The first one being ivacaftor, and most recently lumacaftor and tazecaftor. And then later this year, we will likely hear about the approval of a triple combination Cftr modulator treatment that's likely going to benefit over 80% of our patients with CF. So survival now being in the mid to upper 40s. We expect people living with CF to live now hopefully a near normal lifespan with treatments. And turning now towards newborn screening, the reasons for newborn screening for CF are myriad. The benefits clearly in terms of improved nutrition and growth. And one of the criteria for CF is that you can initiate a treatment based on that diagnosis. And pancreatic insufficiency is in fact a treatable condition. We intervene with pancreatic or digestive enzymes right after diagnosis. Newborn screening has also been shown to reduce nutritional complications, and some of these nutritional complications are in fact life-threatening. Vitamin K deficiency was associated with bleeding disorders and babies dying because of this. So we can avoid those nutritional complications. Certainly, it's been shown to be associated with reduced hospitalizations in infancy, and there's limited data to show that newborn screening also improves long-term survival. More subjectively, in earlier CF diagnosis and referral to CF centers avoids the stress of having a sick baby without knowing why. So some of you on the phone may know, but Colorado was the first state to initiate newborn screening for CF, started in 1982. And it was really largely based on data out of Colorado and Wisconsin showing the benefits of newborn screening that really led to the nationwide implementation of newborn screening. So the next couple slides are just going to show you sort of the benefits from a growth and infection perspective. These were data from the National USCF Foundation Patient Registry. Heather Hoke, a colleague of mine, helped to analyze data from the registry, showing in this first graphic really an improvement in height, weight, and weight for length Z-scores in the year of and the year after diagnosis from the years early 2001 to 2010. It was really starting in the early 2000s that most states in the country came on board with newborn screening, and the last state to come on board for newborn screening was in 2010. And so you can really see an improvement in all of these growth parameters during the course of that implementation and rollout of newborn screening nationwide. In addition, we've seen reductions in infection with Pseudomonas. Pseudomonas, again, is a particular bacterial pathogen we see in people with CF. So we've really seen an approximate 10% reduction in positive cultures for Pseudomonas over the course of that decade while newborn screening was being rolled out, and an associated decreased use of inhaled tobramycin in these babies. So no question, lots of benefits associated with newborn screening, but there are risks and challenges associated with newborn screening for CF. The ones that we face are the identification of genetic carriers, because most forms of newborn screening for CF rely in some way on genetic testing, and so we identify carriers. We also identify babies with an uncertain diagnosis. I'll come back to at the end. That's called CFTR-related metabolic syndrome, or what we abbreviate CRMS, where these are babies, some of whom may develop CF, but most don't, yet we feel the need to follow them to ensure that they don't develop disease manifestations that may eventually be diagnosed as having CF. So part of the risks and challenges is really balancing the number of carriers identified and babies with CRMS compared to the number with a true diagnosis with CF, because that's really the key reason for CF, is making a diagnosis of CF that we can initiate treatments in those babies. And then there are false negative and positive things associated with newborn screening as well. So now we're going to take a look at how a diagnosis of CF is typically made, go through the Colorado CF newborn screening algorithm as well. And so typically you as a primary care provider has just heard back from the CDPHE or from one of the CF providers about a 3-week-old female infant in the community with a positive newborn screen for CF. And it was based on having an initial immunoreactive trypsinogen, or what I'm abbreviating IRT, collected on day of life 1 of 132. Second IRT collected at day of life 12 was elevated 126, and on that same blood spot, genetic panel was run, and you found that the baby has a genotype of 1 F508del mutation and a second N1303K mutation. This is a presumptive diagnosis of CF, which will be confirmed by sweat testing when the baby's seen at the CF center. So looking more carefully or in more detail at this, so immunoreactive trypsinogen, or IRT, IRT is a biomarker of pancreatic injury and exocrine pancreatic dysfunction. Newborn screening for CF begins with measuring IRT, which is elevated in the blood spots of infants with CF because of the blockage of the pancreatic ducts. The IRT, which is produced in the acinar cells of these pancreatic glands, leaks out into the bloodstream, and we take advantage of that and are able to measure it in the blood spot. In terms of Colorado's newborn screening algorithm, it's an IRT DNA approach, which means that up to 2 blood specimens, one collected at about day of life 1 and a second one collected by 2 weeks of age, is analyzed for IRT. And then for those who have elevated IRTs on both specimens, a DNA panel is run. So looking more carefully, if the first IRT is less than 60, it's considered normal and the end of the newborn screen. Here we say normal CF screen, but I will say it does not completely rule out cystic fibrosis. CF is unlikely in this situation, but has not been ruled out. If the IRT is between 60 and 140, a second specimen is run to determine if that has returned to sort of what we consider the normal range, less than 60, or if it's still elevated. We've got 2 IRTs that are elevated, in which it will then undergo Cftr mutation analysis. If that initial IRT is greater than 140, even without waiting for the second specimen, that initial specimen is submitted for mutation analysis. Now, looking on this next slide, the mutation analysis really can identify one of 3 scenarios. So I should start by mentioning that our mutation analysis here in Colorado looks at a panel of 39 mutations, and either 0 mutations are identified, in which case we think there's a low risk for CF, and again, we consider the newborn screen complete in that scenario. If 1 mutation is identified, at a minimum, that baby is a carrier of a CFTR mutation and is at risk for CF, so they need to undergo a diagnostic sweat test to determine whether they do in fact have CF or if they're simply a carrier. And then if there are 2 mutations identified, it's a presumptive diagnosis of CF. They come for what we consider a confirmatory sweat test to confirm what was identified by newborn screening. So newborn screening begins with the measurement of IRT, and it ends with the sweat test, which is measured in a specialized fashion in an accredited lab. There's actually only 2 hospitals here in Colorado that do the accredited form of newborn screening: Children's Hospital Colorado and National Jewish Health. A sweat chloride greater than 60 is diagnostic of CF, either in combination with clinical features or, in this situation, in combination with a positive newborn screen. There are babies who have values between 30 and 60, which are considered intermediate or indeterminate values. Some of these babies will have CF, others will not. And then there are reasons that babies can also have false positive and false negative results for cystic fibrosis. Just to go through a few other scenarios before turning it over to my colleague here. Here's a second scenario: a baby born where the initial IRT is elevated at 91. The second IRT is also elevated above that threshold of 60 at 63. So that baby undergoes, that same blood spot undergoes genetic testing, but no mutations were identified on that panel. So what is the likelihood of CF in this circumstance, and is any further testing needed? Well, it's sort of a rhetorical question because there's nobody here in the room with me, so I'm going to answer it for you to say that CF is unlikely and that no further testing, specifically a sweat test, is necessary unless you have concerns about the baby. So again, newborn screen is not perfect. It's a screening test. If you ever have concerns about a baby, don't hesitate to either reach out to us here at the CF Center or to order a sweat test. But in this circumstance, you don't necessarily need to pursue any further testing. Here's another scenario. The initial IRT is elevated at 232 because it exceeded that initial cutoff of 140. Rather than waiting for the second specimen, CF genetic testing was performed, finding that this baby has one F508del mutation. So the questions are, what are the next steps, if any? So this is a baby who at a minimum carries one mutation, could potentially have a second mutation that's not included on the state's newborn screening panel. So the recommendation is this baby undergoes a sweat test to determine whether this baby has cystic fibrosis or whether this baby is simply a carrier. Another scenario, initial IRT is elevated at 105. The second IRT is also elevated at 72. Genetic testing revealed that this baby has one F508del mutation and a second R117H mutation on the background of a 7T poly-T allele. Does this baby have CF, and what are the next steps? Well, those of us who do CF know that the R117H is really an interesting mutation, with more complicated genetics. And some of these babies will have CF, and some will not. This particular baby underwent a sweat test to help clarify the diagnosis, finding that the sweat chloride was in fact 38, more in that indeterminate or intermediate range. And so this is a baby who's given the diagnosis of CFTR-related metabolic syndrome. Recommendations are that this baby be followed at a CF care center to determine whether the baby will develop symptoms and signs of CF, and further testing can be done down the road to reevaluate whether the sweat chloride is more in the diagnostic range of greater than 60. So just very briefly, CFTR-related metabolic syndrome, or CRMS, describes infants with hypertrypsinemia on newborn screening who have sweat chloride values less than 60 and up to 2 CFTR mutations, at least one of which is not clearly disease-causing. Some of these babies will develop CF disease and be diagnosed with CF, but most don't. Annual follow-up at CF care centers is recommended for these babies. I'll end with an infant in your practice has a normal newborn screen for CF where the IRT is less than 60. Has CF been ruled out? And as I did mention earlier, the answer is no. CF is unlikely, but has not been ruled out. Our false negative rate here in Colorado is probably somewhere around 4 to 5%. Remember that newborn screen is just that. It's a screen. It's not a definitive diagnostic test. If you ever have concerns that a child might have CF, based on malabsorption, poor growth, recurrent respiratory illnesses, don't ever hesitate to order a sweat test or contact a provider here at Children's for further recommendations in this regard. A baby recently born in your practice has a family history of CF, an older sibling with CF. Can the newborn screen process be expedited? And the answer is yes. In fact, CDPHE, or the Colorado Department of Public Health and the Environment, has a newborn screening test request form where you can put a reason that you want genetic testing to be performed. Not only in a circumstance like this with a positive family history, but also in circumstances they'll keep the blood spots for 3 to 4 months, and if there's a situation where you still worry about a baby actually having CF because of early onset of malabsorption and poor growth, we can still have the lab run genetic testing despite a negative initial newborn screen. So that's a service available to you as providers in the community. Here at Colorado, Children's Hospital Colorado, we've prepared a couple forms that can be helpful both to you as providers as well as to your families. One is just an introduction for primary care providers that we share with providers who ever have questions or have a baby with an abnormal newborn screen. We also have a specific form related to sweat testing, what it involves, what it entails for the family, so they know what to expect when they come in for that sweat testing. And anytime any of you have questions about CF newborn screen results or the process, you are welcome to call. We have an on-call CF provider here at Children's Hospital. The phone number is provided here, 720-777-6181, and encourage you to contact us with any questions at any point. So with that, I'm going to end my portion on cystic fibrosis. I'm going to turn it over to my colleague, Dr. Elena Shea, who's going to speak to you about newborn screening for severe combined immunodeficiency.
Rena, did you want to pause here for the questions, or should I?
We have one comment from Gibon, I believe it is. CDPHE keeps spots for 6 months. They are then shredded in autoclave.
That is super. So I'm going to turn it back over to Elaine, but before I do so, to say that Greg Bond at CDPHE just corrected me that they keep the blood spots up to 6 months of age for testing if desired. Thanks, Greg.
We actually have one more question from Stefan, Dr. Mokrahysky. Which prospective parents are advised to have carrier testing for CF before conception?
It's a great question. Stefan, thank you for the question. So, the American College of Obstetrics and Gynecology currently recommends, they recommend consideration for carrier testing for CF for all women who are, considering having babies. Initially, sort of in the late 1990s, there was discussion just among Caucasian women, but I think the recommendation is more broad, that includes all women considering having a big child. Thanks for that question, Stefan.
All right. Well, thank you so much for the introduction. My name is Elena Shea, and I am representing the both of us, Colin Detmer and myself, as the co-directors for the SCID Newborn program. We run here the SCID Newborns program from, we get all the positives from both states, Colorado and Wyoming, and we work closely with the CHDP to make that work. So I'll start with, again, our disclosures. Neither Dr. Detmer or I have any disclosures. I am funded by the NIH, but outside of that, nothing else. So I'll start with talking about the picture that I think most people will be familiar with when they think about SCID, severe combined immunodeficiency, which is the bubble boy, the little boy that was born in Texas in 1970 and passed away at the age of 12, who had SCID and actually received a transplant and then passed away shortly thereafter. We have come a long way since then in terms of how we diagnose SCID and what we know about the underlying genetic etiologies for SCID. So I'll talk about that today. I'll start with some definitions so we are on the same page about SCID, and the incidence for any single one genetic etiology. You're probably looking at an incidence of 1 in 200,000, 1 in 100,000, but if you put all of them together, it's more closer to 150,000. The defects, so by definition, for a baby to have SCID, they have to have a defect in T cells. They may also have a defect in B cells and NK cells, but they must have a deficiency in T cells to be considered SCID. And this defect in T cells, as we'll see later, this can be a defect in number of T cells, but also in the function of T cells. Nowadays, with newborn screening and some of the challenges that we're facing, just like Dr. Sable was talking about, in general, we have done much better with survival, but some of our challenges that we face is that kids that are born with SCID, they actually look quite healthy to their families, and they may not look ill until maybe 3 months old, 6 months old, 7 months old. So we're actually, one of the challenges is discussing with parents who have a baby that looks really healthy to them that they actually have a severe diagnosis that requires transplant at that point. So it is correctable by doing a hematopoietic stem cell transplantation. We do have one replacement therapy currently existing used for ADA, and I think we will start seeing in the coming years more different gene therapy approaches coming down the pipeline, more done in Europe, but we'll see more in the US also. And they will be prime time soon. So a little bit about development of our immune system, particularly as it pertains to T cells. Everything starts in the bone marrow, and cells are essentially pluripotent. They can become any type of lymphocyte, and they must receive certain cues for them to commit to a specific lineage. So you can see here in the picture, you see my cursor? I guess not. Where they essentially go from the pluripotent stage to a lymphoprogenitor, and then they can become a T, B, or NK cell. The T cells have to then go to the thymus to get educated so they can be selected upon. So there's the process called positive and negative selection. And that's really how you then have T cells that come out of the thymus to go into the periphery, who can actually recognize foreign antigen but not react to self-antigen. The T cells are further classified into helper T cells, which is the first category you see there, helper T lymphocyte, and then also the cytotoxic T cells, which traditionally we break down into CD4s and CD8s. So in the definitions of SCID, we have, this is the classification from the JAMA article in 2012. And in general, most people, I think, will classify SCID based on these three different categories. I think from a management practical standpoint, the main difference to make is whether you're a, quote, typical SCID or atypical / Omen Syndrome / leaky SCID. So typical SCID, that means that the total number of T cells is less than 300. And that if we put the T cells to the test, which is what the proliferation to PHA involves, essentially T cells are incubated with this antigen, and you're seeing if they can actually respond to it by proliferation. This is grossly abnormal in typical SCID. And as you can see here, the other supporting features is that there might be some detectable maternal T cells in the peripheral blood, although not always. And then we have leaky SCID or Omen syndrome. As you can see, there's quite a few similarities between the two. So they often have higher number of T cells, which means that they actually bypass the SCID newborn screen test. So then you're looking at about 300 to 1,500 T cells. If they're mostly naive and they're not oligoclonal, meaning that they're not reacting all to the same antigen, then that falls in the category of leaky SCID. If they are actually more of a memory phenotype and they're oligoclonal, then that's really more in the Omen syndrome category. And from a management perspective, the main reason to differentiate those is that if you look at the supporting features in Omen syndrome, the children have the symptoms that you would see that it's a little bit resembling of graft versus host disease, where you have erythroderma, hepatosplenomegaly, and what that means to us is we actually have to immunosuppress as a management strategy, whereas if you have the category above of leaky SCID and you have an incomplete defect, but you don't have any of the other features seen in Omen, then we would not immunosuppress in that scenario, which I know sounds a little counterintuitive. It's in a situation where you're actually immunodeficient, but this is why the classification becomes important, because our management strategies are different. So a little bit about what is really being tested in the newborn screen test. So our immune cells, particularly the T cells and B cells, they're very specific to recognize specific microbial antigens, and that specificity and diversity comes from the ability of having gene rearrangement during development. So every T cell and B cell must undergo gene rearrangement to create a very unique T cell receptor. And you can see that in that rearrangement, there's several enzymes that are important to essentially cut out some pieces of DNA and loop them and ligate them. So if there's a problem in any of those enzymes, then there is going to be a problem in development of T cells and or B cells, and therefore the end result will be SCID. So these little pieces of DNA that are looped out is actually what is measured in the newborn screen test. So if you have a robust number of T cells, then for every T cell that you make, you must undergo this rearrangement. And then if you do that, you have many, many, many loops of this little DNA circle that you see there. So then that means you have a good number of T cells. If you don't have many T cells, then you have very few loops of DNA circles, and therefore that will put you in the SCID category. So that the way we measure that is by that loop of DNA is called a T cell receptor excision circle. That over there is Dr. Dartmouth's son, who is getting the newborn screening card being done there, and he's not particularly having fun, but he's for his own good. And as you can see here, the representation of, again, that when you undergo T cell receptor rearrangement, there is a section of DNA that's looped out, and the little loop there that's called TREC, T cell receptor excision circle, is what's being measured in the newborn screen. So there are thresholds above which we consider that it's a normal number and below which is abnormal. So this is a 2-card screen state, as you also have seen in the case of cystic fibrosis. So then, so say you have the first screen, and if the TREC number is above the threshold and it's normal, that's great. Neither Dr. Dharma and I get a call. If the number is abnormal, then that always gets retested to make sure that it's truly abnormal. If it gets retested and is normal, then again, we don't hear about it. If it gets retested and is abnormal, then there's a measure to ensure that the quality of the DNA from that little card was actually good quality. So then we assess what's the quality of beta-actin, and if that's good, and the beta-actin is normal, that means that actually our measurement of the TREC is truly abnormal. We got a very good sample that shows us good quality actin, but abnormal TREC. That means the SCID newborn screen is abnormal. If the beta-actin is abnormal too, that tells us that the quality of the DNA from that blood spot was not good, and therefore that's an inconclusive result, and we will report it as such. So when you receive your report for newborn screen for SCID, it will either say normal, abnormal, or inconclusive. In either scenario, so we meaning Dr. Demmer and I, get notified whether it's abnormal and inconclusive. And I would say that most of the time, we will essentially say, please go ahead and obtain your second card at the number of days that you would normally do. There are times where actually after the first abnormal, we might proceed with confirmatory test already. That really depends on what that abnormal value is. And I'm going to illustrate some examples that in the cases where actually there's been abnormal SCID newborn screen and there's been confirmed SCID diagnosis, we're looking at TREC numbers in the range of 0 to 5 or even 0 to 10. So very, very, very low. So that means that if the number is higher than that, but maybe not normal, we might just ask you, please get a second card. So newborn screen here in Colorado, as you can see, started in 2012. And I think as an immunologist is really fantastic to see that really over the course in 10 years, we have gone from only screening in one state to really screening in entire US. And you can see the timeline here. So 2018, so if you come out all the way to 2019, you can see that Navajo Nation, Puerto Rico are also screening. So again, really satisfactory to see that in a 10-year course, we have gone from no screening to really screening in the entire country, which is fantastic. So let me talk to you about a couple of cases that we have handled here at Children's Hospital Colorado since we started managing the positives. So we work very closely with CHDP, and the team is fantastic, and they notify us usually the same day when there is a positive result. And they will let us know immediately. So in this case, for example, this is a girl who's 1 day old and born term, and she's found to have an abnormal newborn screen, and here the TREC copy number is 0. right? So again, as I said before, the quote true positives have really been in the range of 0 to 5 or 0 to 10 copies. A fairly unremarkable family history and past medical history, or as much past medical history that a one-day-old can have. And then in terms of social history, they live quite far from here, and we received the result. I believe it was day of life 3, we were notified, and then that same day we notified the family. We brought them into our clinic of day of life 4. And what do we do if we are very concerned that this might be a true positive? We talked with the family first to kind of get a sense and assess how the baby's doing. But as I mentioned, these babies look totally healthy, don't have any issues. So most of the time the parents say, well, baby's doing great. We will ask, because a lot of the families live really far away, if the sort of first line check that anybody can do is get a CBC, right? If you get a complete blood count, and then you can look at the absolute lymphocyte count. So an absolute lymphocyte count in a newborn should be 4,000 or higher. And if you see that that's fairly low, okay, that should give you a red flag already. Ideally, we would like to go beyond a CBC, and we would like to do what we call a flow cytometry assay to look at the number of T cells, B cells, and NK cells. And that's what's illustrated here. So you see here that is boxed in bold, the initial evaluation. So you can certainly get a CBC, but a CBC will just get you total lymphocyte count. And that, I think, can tip you over some already, because newborns have a really high lymphocyte count. If it's not above 4,000, if it's 1,000, 500, you should be then at that point fairly concerned. We would like to see the breakdown of that lymphocyte count, and that breaks down into T cells, B cells, and NK cells. And the way that we can assess that is by flow cytometry, which is the assay that's illustrated on the right side of the screen, where essentially the cells are staying with some antibodies, and these antibodies attach to surface markers on the cells that luckily nature was helpful to us. So every T cell has CD3 on the surface, every B cell has CD19 on the surface, and every NK cell has CD16 and 56 on the surface. Those are things that those antibodies can detect. So we ask for a blood sample, but then it's mixed with these antibodies, that then it's run through a flow cytometer that detects the fluorescence of those antibodies. And if you don't get a whole lot of T cells or B cells, that's then fairly telling. Right? And you can see that described here in the box, where you look at here CBC/differential, CD3 T cells, CD4 T cells, CD8 T cells. If the T cell number is greater than 1,500, then we say, well, that's good. Maybe that was a false positive at newborn screen. I will say that if your TREC count is 0, that hardly ever happens, to then have a really robust number of T cells. Then the other part that can really help us, where we assess also with flow cytometry, just like you see the assay on the right side, is that if you do have some T cells, if you remember the distinction of category of typical SCID versus leaky versus Omen, was to look whether the T cells had a naive or a memory phenotype. Nature was also kind to us, and so naive T cells have CD45RA on them, and you can see that in that bold square, that we're looking for the percentage of CD45RA naive T cells. We want that number to be high. That tells us that the thymus is working and is putting up a lot of baby T cells. If that's not the case, that's a problem, and we're concerned. You can see here in the flow chart that if you get low T cell numbers, then you go down to the SCID category, and depending on how many T cells you have, then you're in either the typical or the leaky category. Having said that, there are many other reasons beyond SCID by which the T cell number would be low, and I will talk more about that in my next couple of slides. So going back to this case, we got to the point of abnormal screen on first card, CBC also abnormal, and then we perform flow cytometry here. So we will contact the family, and we will try to also we always contact the pediatrician. Also, we ask them if they can have access to a CBC, that's great. And then as they draw that blood, we also ask them to send us a sample to be able to do the flow cytometry assay here. And this is the result ratio that we got. So that's the number of T cells, CD4 T cells, CD8 T cells, B cells, and NK cells. And you can see in this scenario, there are no T cells or B cells, but they are NK cells. In a sort of pictorial depiction of that, going back to how immune cells are formed, the HSC is basically your pluripotent hematopoietic stem cell. It can be anything. Then it starts to further commit. And then you can commit into the lymphoid lineage, and you can be TV, NK, and there's specific cues that will lead to that. So if you have a problem along the lines of any of those, then you will not get to full development. So the way we classify SCID and how we arrive to different genetic etiologies are mostly based on this classification, where, like I said, by definition, you have to be T minus to be SCID. So then you can be either B plus or B minus, and then you can be NK plus or NK minus. So the defects, as in this patient, for example, you saw is a T minus, B minus scenario, and there's NK plus. And then there's this category of different genetic etiologies. The way I like to sort of think about the framework of categorization of SCID is that if there is a defect that affects gene rearrangement, that's going to be a T minus, B minus scenario, because T cells and B cells need gene rearrangement for T cell and B cell receptor. If you have a problem that's a metabolic problem, so the cells need to be able to metabolize ATP to develop energy to do their functions, well, that's something that affects every cell. So that's a T minus, B minus, NK minus scenario, like the case of ADA, for example, or AK2, dyskeratosis congenita. And then the problems where is T minus only, as you can see, T minus, B plus, NK plus, then you're in the scenario of genetic problems that affect only T cells, or maybe is not a problem in the genes involved in the cues for T cells to become T cells, but actually it's a thymus problem. And this is where we get a lot of the syndrome issues, because if you have a syndrome that affects development of the midline structures, the thymus happens to be in the middle. And that's the situation for DiGeorge, for example, and Charge. There are other disorders listed here, like FOXN1, PAX1, TBX1. The reason why they're there is because they are important for the other cells in the thymus that nurture that T cell development and education to happen. So if that education is not there, then the T cells can't really do very well. So this is how we think about the classification. So on our patient, we know that they are T minus, B minus, NK plus. Okay. So what do we do next? After flow cytometry, then we also pursue genetic testing. Our genetic testing, unlike for CF, is not through CHDP, to the CHDP. We actually see the patient, and then we have to pursue authorization. We have to follow the usual steps that we do with other patients to do genetic studies. And then here we go into the different classifications of types of RAG mutations. So as I mentioned before, in our patient, this is a patient with T minus, B minus, NK plus. Therefore, this is a problem of T and B cell receptor rearrangement. RAG is one of the enzymes that is required for that rearrangement. A compound heterozygous, it just means that there's two different mutations in each of the alleles. And for mutations in RAG, there's been several flavors described with it. And they are mutations that result in a typical SCID, which is basically the scenario that I described before of less than 300 T cells. And essentially very low T cell function. So very low proliferation of T cells. And then there's Omen Syndrome, which is the part where I described like a graft versus host type of disease, where you have the few T cells that you have doing damage to its own organs, and we have to immunosuppress there. Then there's another category of atypical SCID, where there's basically low T cells, but there's no that GVHD kind of picture. And then this is called combined immunodeficiency with granulomas and autoimmunity that was just recently described. And so this patient was transplanted shortly thereafter here. In fact, the day that she came into our clinic, we essentially had them wait until we got the flow cytometry results, and then they can get admitted actually directly to our transplant floor from there. Not to get transplanted immediately, but to get care in the bone marrow transplant unit as all other things are becoming unfolded. So then this is the other case where this is a 1-day-old boy that in the first screening card, again, TREC number of 0. There were no anatomical abnormalities, so we always pay attention to that for the syndromic cases that we described. Fairly unremarkable history. They also live fairly far from Children's Hospital, Colorado. So we perform our flow cytometry assay, and then you can see now that actually there are no T cells, but they are B cells present, and they are NK cells present. So this is a different scenario. This is the T minus B plus NK plus. So we're either dealing with a defect at the level of the thymus, or it's a genetic defect that affects commitment or development of a stem cell into T cells. So those cues or signals here that are needed for that could be defective. So we followed up and also performed genetic testing. But before I get there, I'm going to give you a little bit of categories of non-SCID conditions that can lead to low TREC counts. Because in those conditions, usually it's a situation of T minus only, where there are B cells and there are NK cells. So there are those genetic syndromes that actually affect the midline, and the thymus happens to be in the midline. And depending on how much thymus you have left, then that determines your degree of immune deficiency. If you have athymia, no thymus left, then that's fairly significant. And that can be the situation in DiGeorge, although not every DiGeorge patient has no thymus. Many DiGeorge patients have a fairly functioning amount of thymus left. Then these other genetic defects, charge also affects the midline, and then FOXN1, PAX1, as I mentioned, very important for the development of the thymus tissue. These are other genetic syndromes where low T cell numbers have been described, but they're not particularly problems with thymic development. And then here, there are other immunodeficiencies that are essentially would lead to low TREC counts, and some of them, I know here it says it's called non-SCID. So it's called non-SCID as in the traditional SCID definition, but these patients, right, the ZAP70 deficiency with ZAP70 is very important for T cell signaling. That probably means that there's a T cell dysfunction. So the numbers might not be low, but the T cell is not working, which still leaves you in the category of a T minus. Having T cells there that don't work doesn't really help you any. And then MHC class 2 deficiency. So that's actually not on T cells. This is a protein that's on the other cells that need to help the T cells recognize antigen. So again, you have normal number of T cells, but they just cannot recognize antigen. So therefore they cannot function, and they don't really do you any good. And then these are other scenarios. I would say, by and large, most of the, quote, false positives that we get of newborn screen, basically an abnormal newborn screen for SCID, it's most of the time it's going to be prematurity or very low birth weight, because in those cases, little babies just don't have a lot of T cells, not due to immune deficiency, but just prematurity. So back to our patient, which category does our patient fit in? Well, we performed fairly expansive genetic studies. We did, this is a T minus, B plus, NK plus category, right? So we did the genetic panel for that. That was negative. Then we just opened up to go higher. And essentially, we then did the genetic panel that includes all the SCID genes plus the combined immunodeficiency genes, so other more expansive ones where the T cell numbers could be higher. So we went bigger, and that was also negative. And then we went to whole genome sequencing. So not whole exome, but actually whole genome, and that was also negative. So this patient is actually still with us in the hospital. And there is no denying that the patient has a fairly significant thymus problem. So there's very, very few T cells. And the way that we understood this, so a lot of what we do in immunology, actually, there are some clinical assays that we can do to identify the etiology. But frankly, a lot that we do is actually requires collaboration with research labs. And we have a fairly collaborative network. And there are some assays that you can do in the research side to essentially take the T cells of these patients and then try to force them to give them all the right environment in a little dish or flask to say, can you develop into something more if I gave you a pretend fiction thymus, right, in a plate? And if you can, that means that indeed you can do that, you're just missing a thymus. Or if we give you a fake thymus and your T cells don't develop, then that means that it's not really a thymus problem. That means that even if I gave you the right environment, you can't develop, and that's a T cell intrinsic problem. So by the way of this research assay, we're able to identify that this child has a thymus problem, but we actually don't know exactly what's the genetic etiology underneath. And some of it, when I say it's negative, I think for all of us that do genetic studies, whenever you do studies, you only find what you're looking for. So depending on what filtration strategy you do to look at the genetic data, you may come up with some hits or may not come up with other hits. So some of it is how you explore the data. But that's not unusual nowadays in terms of understanding genetic etiology for SCID. So if you look at what the breakdown was, this is before newborn screen. You can see that really the majority was excellent, right? So this is your traditional IL-2 receptor gamma defect. And this is the day where children were diagnosed by the time they were 3 months, 6 months old, like 668 come in and it's like, oh, this happened. There are probably a whole lot of other kids who passed away before they really received care who had SCID, but nobody diagnosed them. And then you come to the era of newborn screening where most people are now picked up at birth, and then you do genetics fairly quickly once you confirm the diagnosis, and you can see how the breakdown of genetic etiologies really has changed, where X-linked SCID now is really just 19% of the pie, right? Because we have now come to learn about so many of the other genetic etiologies, but significantly, look at this 20% of the pie is called unknown unspecified, meaning that we look for our usual suspects and none of the genes turned up positive, and we go beyond our usual suspects into more expansive whole exome, and we still don't find a specific gene etiology, but there's no denying that they don't have T cells, that they don't have B cells, right? And this is a conundrum that we face. And I think as we learn more and we get better with screening, we get better with genetics, and hopefully we do better in terms of assays to understand immunological function, we will be able to have the pie sliced even more with more new genes, but this 23% hopefully goes down. So thank you so much for your attention. Dr. Colin Duttmer and I are happy to answer any questions if you ever get a positive result. When you call, that actually comes directly to us. That number that it tells, please page Children's Hospital Collaborative's number. That's Dr. Duttmer and I, and we're always happy to answer questions.